for Emergency Medicine News. One of my articles, this one was back in December of 2015, was entitled "To Code or Not to Code," and so it really talked about whether or not physicians really understand advanced care planning and physician orders for life-sustaining treatment. And so I've been talking about this for some time now. And then we have this case in Florida about DNR tattoos and whether or not to follow them. I'm curious to hear what your all thought is on that, and I'm sure that'll provide some interesting insight.
Let me give you my background on this, Carlo. Having reviewed cases now for 42 years, over 2,400 cases, I don't think I've ever had one case which turned on whether there was a tattoo or not about resuscitating or not resuscitating. I think that it's mostly on the judgment of the doc at that time. I mean, if they've been beating some guy in the field and have gone through the drug box 3 or 4 times, they're dead. I mean, whether it says save me, don't save me, please save me, there's only so much you can do, isn't there?
No, but this is actually a different story here. This is whether somebody who comes in who is unable to speak to you, who is unconscious, whether that is a bona fide, lawfully valid request. And this article that was in ACEP Now, which was written by, let's see her name, Laura Vernier, who is a clinical assistant professor at Drexel in Philly, wrote this piece and made it very clear that you can't be following this for at least 4 or 5 reasons that you can't do this. And
well, in case you guys don't remember, about 85% or 90% of tattoos are usually put on when you're drunk and stupid and going crazy. And so what makes you think there's any more validity to this tattoo than the one that says has his girlfriend's name, his three girlfriends ago, on the back of his arm?
Although it's kind of interesting, she relates that the emergency people, when they saw the do not resuscitate, were going to basically not particularly be aggressive about this person. However, they got a consult from an ethicist. These are directly from God. You know,
they
have a pipeline right to God. Here's the right thing to do. And the ethicist concluded that the two could be presumed to represent the patient's authentic preference, and that the law is sometimes not nimble enough to support patient-centered care and respect for the patient's best wishes. So this ethicist is saying this tattoo is legit. But then again, she goes down the list of reasons why it is not. Why you shouldn't do this.
It sounds to me like she's a higher quality ethicist involved in this case. Carlo, jump in here.
She's just writing about this case. Well, the first point was, Carlos, you might respond here. Tattoos are not legal advance directives nor POLST.
Absolutely not. There's no way that they can be. I was actually shocked. I guess shocked is too strong of a word, but I was surprised that the ethics committee said that, well, yeah, you could have followed it. I mean, I think any practicing physician would probably take the road of let's do more because we're just not sure what this tattoo really means with regards to the patient's preferences. So I totally agree with the doctors that are literally staring at this patient when the patient rolls in. I mean, how can you follow it? So it was interesting that the ethics committee said that. And I'm not sure if that had something to do with the way that we interpret documents generally. So, for example, if a patient comes from another state and fills out a POLST, and they have, let's say I'm in California and I have a Minnesota form that says don't do anything, right, or something like that, right? Limited measures, whatever it is that it may say. The general rule is that tends to suggest, or that gives good evidence as to what their preferences are. It doesn't necessarily mean it's entirely enforceable, but it is something that could be used to guide. But that is, that shouldn't be the same level of certainty as a tattoo, right? I mean, or the tattoo can't be the same level of certainty as another state's document.
Well, as an attorney, if that tattoo has also been signed and notarized, now that would be a different level of tattoo. But I mean, in case, I'm just going to say, if you live in emergency departments like we do, you see the damnedest tattoos. And more than that, if it's a 24 or 25-year-old guy who's got this on his chest and not a 90-year-old who has also proven cancer, I mean, you got to look at the situation here a little bit, folk.
Well, there's a premise in medicine that says, when there's any doubt, resuscitate. And later on, if it's determined that, they really wanted to die and they had the right to die and they were capable and they had all the paperwork, well, then somebody can trip on the cord to the respirator and deal with it at that time. But the general principle for ER docs is treat.
Yeah.
Now, the second point she made was informed decision-making cannot be presumed. Lots of people have no idea what a DNR means. I didn't know I didn't know they were going to, help me out here. Number 3, she said, the tattoo provides insufficient information to guide medical treatment. Does it mean no chest compression, no intubation, no vasopressors? Advanced directives and pulse clarify preferences.
Absolutely. And in fact, a pulse form since it is a physician order, it gives a little bit more clarity than an advanced directive with regards to the types of treatment that a patient prefers.
And let's, just for going back to the basics, Carlo, what does pulse mean?
So POLST stands for Physician Orders for Life-Sustaining Treatment. And almost every state statutorily accepts a form that indicates the type of treatment that a patient prefers after counseling with a physician. So a physician and a patient both sign it. So it's actually an order, a physician order that emergency medical services and physicians across transitions of care should follow. The confusion, and I reference the Mirachi studies that have indicated that there is still existing confusion among physicians, including emergency physicians, about how to interpret a POLST and what is the difference between a DNR and a POLST, et cetera. And so I think those studies demonstrate that there is still an information gap about the impact and the utilization of POLST.
She also points out that the end-of-life preferences are dynamic. A person's preference may change based on a large variety of circumstances, and you could understand that for sure. I changed my mind.
It could be, but again, I'm willing to bet there aren't two of these situations a year in the United States where you've got somebody who actually is salvageable, who has "do not resuscitate" scrawled on their chest. I mean, it's got to be pretty damn rare.
You got to acknowledge, though, that more and more people are getting tattoos. I mean, I've seen these 40, 50, 60-year-old people with tattoos. And when you have tattoos, you've got to show your tattoos. So if they're on your arm and you get the guinea teas, it's a whole lifestyle here, man.
Yeah, I understand. It's all you California raisins who are coming up with this stuff. Before we carry on this furor loquende, talking about this stuff, I'm sure there's another subject which Carlo would like to get into.
Well, can I do one thing? We got one more point here that she makes. Tattoo regret is common. More than 50% later regret their tattoos.
Are you kidding?
When you put Mary, now it needs to be changed to Joe.
Right.
That's not easy to change those tattoos like that.
It's not easy to change, exactly.
So those are the legal elements that make it very clear that this person, you cannot honor their wishes. Moving on.
All right. So yeah, there's a kind of a corollary here, and kind of continuing on with the Pulse discussion is the idea of the accessibility of a Pulse, because if it's filled out but it's either not found or if it's not followed, then the question becomes, is there liability there? And there's actually been some cases that have demonstrated liability when a physician either doesn't follow a Pulse, or let's say the healthcare system doesn't reliably store a Pulse, so it's not accessible to clinicians. And this is actually a growing concern as well.
Carlo, I would love to know, and whenever I'm meeting with other guys who've done thousands of cases, have you ever seen a doc sued for just calling the code and somebody come in and say, oh, no, they wanted to live and you should have done this and all that kind of stuff? It's usually the other direction. You've done too much. You beat the hell out of my mother who wanted to die anyway because you couldn't find the pulse. And she didn't want any of this stuff. I mean, if there is a case out there, I think we're talking about rarity here.
Yeah, I mean, there, on the one hand, there are wrongful life cases, in the sense of the patient had wished that nothing, there'd be no intensive treatment, and then something happens, and then you find out that they have an advance directive or a Pulse, and then you find out also that it was basically ignored. The flip side I don't see it that commonly, but I think that the legal concern and the risk concern is valid on both sides.
Carlo, do you have to bring it with you, or where did you keep it, in the refrigerator? And how does this process work to have the healthcare workers know that you have one someplace?
So the initial thought when Pulse was implemented was the idea that it would be a bright pink form. It would be on a refrigerator, and emergency medical services would be trained to look for it, and they'd bring it in. But my goodness, we live in 2018, and we have internet, and everyone has cell phones, and so now there's a movement towards creating electronic registries on the cloud. So what we'll see is, as we get more accessibility with Pulse in the internet, in terms of that type of thing, that will provide a new means by which this important information can be shared when a patient is calling, or a patient's family is calling 911, or they're coming in from a skilled nursing facility, so that everyone can see the same form in real time.
Because there does seem to be the risk that a patient has a Pulse, but it just doesn't get brought in with the patient. It got lost someplace, and the nice thing about having a tattoo is it comes with you. That was one of the points that they made. You haven't lost it.
Yeah,
where did I put that thing?
Yeah.
I know. Right. I mean, you can't lose it. You can't lose a tattoo. So. Right. Absolutely.
Yeah.
I think Greg's idea, Greg, I think your idea of, you could start a little business, Greg. Get get the notary thing, get a notary tattoo, and a little signature in ink, indelible ink. You're in business, man.
There's lots of things here. By the way, the problem with putting it on the cloud is, what if the Russians hack our cloud and declare that everybody is non-resuscitatable, and then they can just invade the country? I mean, be careful here, guys. There can be problems. Carlo, before we move on, I've got a question I want. Diane Birnbaumer wants me to ask, I think, and that is, because Diane asked me, I mentioned a case a few months ago in which one of the pleadings in the case, which had to do about purposeful and deliberate misrepresentation, a nurse / NP / doctorate in nursing called herself doctor in front of the patient. And now there's a problem. And the patient now says, and it's in the pleadings in the summons and complaint, the patient misrepresented themselves as a quote unquote doctor.
Ah.
And the nurse in her deposition, let's say she's got her ego up or whatever, and said, yes, I do insist that the other people in the department call me doctor. What do you think about this? Because to me, the common parlance is it's an MD or a DO if you're giving care in a medical setting. You know, there's doctors of pharmacy and there's doctors of histology and all that other sort of thing. But if you're giving care and you call yourself a doctor, is that misrepresentation?
You know, it certainly feels that way. You know, I'm not aware of this case, and I guess I should premise everything I say that none of this is legal advice. But
we just better shut down right now.
Yeah, we've been giving it out for years, guy. Don't you worry. Yeah. You're just another name when they sue us, so that's it.
But yeah, certainly, I think that you know, when you're in a treatment setting, a medical setting, and you say doctor, and again, no disrespect to, you know, people that hold doctorates and other degrees, but I think that the importance is really understanding how the patient understands the words, right? So it's more important if you have to be clear and you have to be more precise in your language to make sure that the patient understands it, then so be it. But again, if you're not precise in the language, then it could cause some misrepresentation. That would be my first gut response.
Yeah. If we're going to give out advice to the people who are listening, the patient should understand everybody's role in the situation, i.e., I am the advanced provider, I am the physician, I am the tech, I am the this, that, or another thing, and it should be clear to everyone. Would you agree with that?
100%. I mean, it's kind of like the timeout that we're all supposed to be doing before procedures, and everyone tells the patient what their role is and why they're there. I mean, that's really just informed consent. So anything that impacts the potential for not achieving informed consent would result in potential liability ultimately.
Yeah.
Well, this has a opportunity to become a much bigger problem. There are about 225,000 nurse practitioners, and if you want to become a nurse practitioner now, you are unlikely to graduate without a doctorate of nursing practice. So there's going to be many, many, many more. And in addition, there's a move to have already established nurse practitioners go back and get these doctorates of nursing practice. However, to deal with this issue that you've talked about, some states are making regulations that have the terminology that in essence says you cannot say you're a doctor, implying you're a physician in healthcare settings. And I don't know the wording, obviously, and the wording would have to be relatively careful. But the fact of the matter is that this is a real problem, and you can see where it would lead to substantial difficulties. And so it's going to be handled on the state level by saying you just can't do this.
Well, I think that this particular plaintiff's attorney, when he said, and this is a quote, purposeful, deliberate misrepresentation. You know what? I kind of agree with him on that if this gal has been calling herself Dr. So-and-so and the other people, that's not the common understanding in the public at this moment in time. Oh, well.
Moving on. Carlo, do you have another one?
Yeah. This was actually an article I wrote in February of 2013, and it was it's entitled "The Pain Prescription Epidemic: Are EPs to Blame?" And you know, there's been so much. I mean, that's 5 years ago, and
I can't believe that you wrote that 5 years ago.
Yeah.
Do you realize that you've just hit a hot button for both Rick and I. I mean, we yell and scream about this at all the EMA courses, everywhere else. But tell us what you said in the article.
I hope we agree with it.
I hope we do too.
Well, I mean,
we just cut off his microphone if we don't. But go ahead.
well, kind of thinking back again, it was a long time ago. I basically said, EPs are not to blame, but we can be a positive influence in terms of, how prescribing, opiate prescribing is done. I do think that the reason why I said that is because EPs, emergency physicians, stand in a unique situation in which we don't have that continuity of care. And so I looked at it from a risk management perspective. If we don't have that continuity, we could be unwittingly continuing a patient's dependence because they're just going to hop from one EP to the next, and hence the need for some kind of collaboration or something. I know that there are states that have prescription databases, and I've written on that too, and I've gotten a lot of heat for some of the things that I've said, but I certainly don't think that we're the blame, but I think that there's a system issue that we need to address. Yeah,
that certainly can be the case. Rick and I on this program have talked about the new Massachusetts law, with the new law in West Virginia prompted by the Tug Valley Pharmacy case. All of these things where there's more pressure coming on the docs to give fewer and fewer meds. I honestly believe that as I read more literature, the opiate addiction problem, there are solutions to this. I think Suboxone has a role. I think that there are other ways that we can deal with this, and we can't just throw up our hands. I think you're right. ER docs have to remember that they're a little part of the chain, but they're in there. So do what you can to move these people in other directions. And one problem is there aren't a lot of pain management specialists in the country right now. Every one of them I know has got a lot of job offers because this is huge.
Yeah, we're pretty limited in the emergency department in terms of what we can do with regard to pain management when people are discharged. I'm not concerned really what happens in the emergency department, although it does fry me a little bit when you read an article that says we're the the opiate-free emergency department. I just freak on that one. I have to give some acknowledgement to Sergei Motov, who I think really, really knows a lot of stuff about pain. But I think he was really off base when he kind of talked about, well, we'll give you an infusion of acetaminophen, and we'll give you an infusion of lidocaine, and we'll give you an infusion of ketamine, and we'll give you an infusion of, what was the fourth thing that he gave? And you would get these 4 infusions for your pain in the emergency department. When in fact you're going to give him 4 milligrams of morphine, for crying out loud. It's not. It's not that what's going to cause your problem. And even in the studies that show certain people after they get out of the emergency department, 6 months later they are much more likely to be on opiates. Well, who are the people prescribing for the 6 months? It's not us.
Right.
They went to some doctor, and he kept writing, she kept writing over and over and over. It's like maybe they ought to take a look and say, well, to tell you the truth, I think we ought not do this as long as we're doing it. Or I think we have a teeny, weeny bit of the blame. And I also think we're a huge opportunity to be a part of the solution because of, I believe, we are the ones who see these patients. They come to us, and I think that some of them are coming in suits. They're not just all shooting up in the back alley kind of thing. And there are no programs of any consequence out there to address the idea of treating people who are addicted and treating them in a way that is analogous to treating diabetics who with insulin. You basically give them, here's a substitute. The substitute will allow you to go to work, raise your kids, make money, stop robbing, and it's called buprenorphine. So it's like there have been some really neat programs based in emergency departments, getting you quickly into programs where they can initiate Suboxone in the emergency department. And but it's obviously not the only, that's just the beginning. But
Carlo, the banging you hear in the background is me busting up his soapbox. When I told you that you hit one of our hot button issues,
all right, never mind.
We gotta let him talk, right?
Roseanne, Dana, never
yeah,
mind.
Yeah, whatever. Right.
All right, let's move. You want to do something else? Or did I just steal your thunder there?
Yeah.
Well, no, I think that's pretty much in terms of my initial article, again, 5 years ago. I wanted to kind of diffuse the idea that all the ER docs are really responsible for this, And then, it's interesting that there's a recent study that is, I forgot who wrote it, but it was just recently in that said that opioid prescriptions written from the ER were 23 to 37% less likely to have a dosage higher than the 50 morphines equivalents compared to non-ED prescriptions. So kind of just saying that, we actually prescribe far less than non-emergency physicians. And so I hallelujah, I didn't know that. I was waiting for a study like this to happen because I think that ER physicians kind of know that, we're going to treat your pain when you're in the ER because your bone is in the wrong place, and I'm more than happy to give you the opiates to make you feel better. But, when it's time to go, we're not your continuity care doc. We're going to give you a small amount. And then it's that 6 months that you mentioned where what's happening there. So, we really need to have maybe some type of coordinated response, which you suggest, in which we have collaboration with a conscientious pain management program or a physician.
I think the perfect people as we age, and remember, Carlo, you're talking to two dinosaurs here.
Hey, speak for yourself there.
Yeah. But as we age, this is another area like end-of-life care, chronic pain management care, that the emergency physician maturing their career, this is something to go into. We've seen it all. We know people who have pain. I think this is something that we're not teaching enough about in the residencies.
Absolutely. I mean, when you think that you need a pain management specialist, that is a area of knowledge that I think, we're treating pain every day. Why don't we have more of that specialty under our belt, So wow, you bring up a great point.
Well, we do a lecture in this year's EMA course where we talk about a whole wide variety of supplemental things that people can do, like the injections for the femoral fractures with the bupivacaine to decrease the amount of analgesics you would need for a hip fracture kind of thing, and the idea of combining ibuprofen and acetaminophen, the idea of heat and cold, the idea of TENS units, the idea of these trigger point injections, whole variety of kinds of things that we really generally don't even think about doing, but there are others. But I don't really feel comfortable with, well, here's your handful of Tylenol. And he said, Doc, I've been sitting out here for 4 hours and you're going to be a handful of Tylenol?
Yeah.
Come on, come on. And worse yet is the Tramadol. Don't do that.
Yeah, Carlo, I warned you.
I'm going to shut up.
The Roman phrase, furor loquendi, it fits Rick perfectly. He's on a rage or a terror to speak on this issue.
Well, listen,
and we have to stop him.
Let's talk about risk management then. Let's get back to the business in hand here.
Well, can I get Carlo to comment on somebody who wrote to us and see what he has to say? Carlo, you spend a lot of your time in an academic program. You speak to residents. We have a letter here. My name is John C., PGY2 in emergency medicine. Was wondering if the risk management panel, which you are a part of today, has recommendations for further reading on risk management outside of podcasts like journals, etc., was wondering whether risk management monthly panel is able to how do they find their cases? How do they do this? Basically, he's looking for a way to keep up on risk management. Now, I was part of the thing in ACEP that turned out 3 editions of the book, Risk Management and Emergency Medicine. I don't know why they aren't introduced that and keep that in their libraries in the departments. And I think there are plenty of places they can get risk management monthly, Rick.
Oh, gee, what an idea.
What a radical idea. And I honestly think somebody in each department, maybe it's one person, gets it and talks about it at the department meeting when there's a real shift or a real change in policy or dangerous things coming down the road. An example is the great discussion we had with Bob Bitterman about this psychiatric case in South Carolina about them deciding they should have called in a psychiatrist to clear and decide what the care should be. This is a big issue. This isn't a small issue. I mean, every night in the department, you've got 10, 15 psych cases that you got to do something with. So what do you tell your residents to do to keep up, Carlo?
Well, certainly kind of listening to you guys and also reading emergency medicine news and risk management columns. I mean, there's a lot that's out there that will kind of, what we're trying to do is we're trying to understand what are the most pressing issues, right, in risk management. So we try to call those, kind of identify those issues. And so I think we're doing the job that needs to be done. But from the perspective of a residency training program, I think there could be a couple of things. And I actually wrote on this a long time ago about how medical school and residency does a really poor job in risk management generally. I think emergency medicine probably does one of the best because we are, emergency physicians are risk averse to begin with. So, but things that you could do from a residency perspective is to have a column, for example. Like, for example, we actually publish semi-regularly some, whether it's cases or concepts, and it's distributed among the residents in our program. So it's a means by which the residents can get very active in risk management generally. But again, the other thing that I've always thought that residency programs need and medical schools is actually a more robust risk management program. I think starting while you're in medical school is probably the kind of like the A+ way of doing it, but actually incorporating it into resident training would be really important.
I've done over 110 residencies now, visits, talking to the residents. One of the best I've seen was at the University of Iowa when Hans Haus came in to run that. He said, risk management isn't going to be a tack on. When they present a case, they have to talk about the medicine, they have to talk about the disposition, and then they have to talk about the things that can get us in trouble with this case on each and every case. And I think that's fair, because it shouldn't be a tack on occasionally done. It ought to be a part of your thought process, because when you get out as a practicing doc, 85% of people are discharged home. That's where the lawsuits are.
100%. And so Hans was actually one of my senior residents. So I haven't seen him in a long time, but wow, definitely true. Incorporating it into residencies would be such a great thing to do.
All right, next topic.
I'm going to do a little, I know that this is a hot button, but there is a corollary to this as well. And I'm curious to hear what your thoughts are on the PDMP. I got a lot of heat for an article in which, and this was recent, December 2017, and I was just kind of going over some general ideas. I talked about sepsis a little bit, and then my next topic was on opiates. and whether or not there is liability if you don't check a Cures data report. And what are your thoughts on that?
Well, I want you to review the concept of a per se violation. The fact that if it's a rule and it's out there and you don't do it, are you per se guilty of malpractice at that moment in time? This is the problem we're having with the sepsis bundle stuff. You know, it's written down, and if you don't do it, are you guilty? You could extend that to almost anything where there's a governmental requirement to meet some need.
Although,
go ahead.
As a distinction, the sepsis thing, which we can talk about, is whether you have done all of the elements to be acknowledged as meeting the guidelines for that care of that patient. That doesn't relate to if you didn't do it as malpractice. This is suggesting that if you don't follow the law in your state and something happens, what kind of mess are you getting yourself into? Because some states require that you look on every patient that you're prescribing, and others allow some discretion. Carlo, what do you think?
I think it's a risk. I think that's why I wrote the article, because and using the December 2017 article, those two topics went hand in hand, right? Because you have the sepsis bundle and you have protocols that you're implementing, right? So you're really creating a clinical guideline. Then we could talk about the legal impact of clinical guidelines generally, right? And then looking at opiates, this is not just a clinical guideline, this is a statute. And so I do get concerned about that risk. The purpose, one main purpose of the article was not so much to kind of turn on the siren and be sensationalistic, but it was really a concern that I have is that when you have these laws and you have these guidelines, and let's say that you have doctors that aren't aware of it. Let's say they're not aware that they should or they're supposed to review a Cures database, right? Then they're unwittingly at risk. They're unwittingly might create risk for them when they practice that way. And I had a really heated response from a reader who basically said, "Why are you saying this? Why are you publishing this and letting all the attorneys know that this is actually a way to sue docs?" And I replied, there are many attorneys much smarter than me in litigation that already know this. It's not something that I don't think I'm stirring a pot. I actually want to make sure that given these liabilities that we kind of need to know about it as part of our practice. And I still practice emergency medicine. So,
yeah, you know that at the New York City hospitals, you cannot give out more than 3 days worth of an opiate. And what that's done is basically taken emergency docs who maybe this person is going to have pain for 5 days or 6 days. The joke is we think all of these people have access to a primary care physician who's going to take care of the situation. And I think in the rage to blame somebody for this, emergency docs, you can hear the question line in court. Doctor, did you check the state database to see if this person has gotten any other medications, yes or no? Because, for example, in Massachusetts, you must check the state database on everybody who gets their 10 Vicodin tablets.
I know. Talk about that. Now, that is a clear requirement. Fortunately, there are more states. In the states where it's not a requirement, that don't have that statute. That adds the a sense of kind of discretion, which is important, which we always want to keep. But it's scary, because I think when you have legislation that tries to tell us how to practice medicine, and in some states they're successful in doing that in certain aspects, we have to know that it's there. Because obviously if you don't, then every time you don't follow a statute, that's a problem.
Carlo,
That's a
We
per
reviewed a
se
case-
violation. Yeah.
We
Yep.
reviewed a case of a new doctor coming on who was not, I guess, familiar with the rules and regulations of the hospital or even the community. And they, as a result of that, they didn't do something that they should have done. And the long and short of it is that the conclusion of the paper, they suggested that if there are policies that are really important, that the physicians and other clinicians in the department should sign in writing that I understand, that I have gotten and understand the policies. We're talking about policies like going to the drug database, child abuse, reporting lapses of consciousness, this whole litany of kinds of things where you would not necessarily intuit them, especially if you're a new doctor coming into that state. You wouldn't know about that. And yet you jeopardize the group substantially and the hospital substantially when you shrug your shoulders and said, I don't know that. So, and I dare say I would be willing to bet $1, that there aren't any groups out there that say, here's the list of the policies that you need to know to work in this department. Sign here, check, sign here. So that basically says, we did it. We were not negligent. We advised them. It explains it. They signed here to basically try to shelter themselves from this liability when one of their guys screws up on something that was obvious that he should not have screwed up on. So I'm going to ask you, Carlos, does Las Robles have you guys sign that I'm aware of this litany of policies?
Oh, I don't even read it.
All right, I want my $1. Send that $1.
I just sign whatever. No, I'm just kidding. There's an onboarding process for any hospital. They make you sign all kinds of stuff, and that is a concern, right? Because when a new doc, just like you said, here's the scenario, right? Just out of residency, has no kind of street smarts about practicing medicine or getting into a medical staff. And what usually happens, I'm curious to see what the current experience is, but 15 years when I did this, there was a big thick packet of bylaws, and I'd signed probably 20 times, and I admit I didn't read all that stuff. Now that I'm on the MEC and I'm administrating the group and this and that, I read everything. And now that I'm an attorney, I think I'm charged with having to read everything. And there is a lot of stuff there, and it's very kind of glossy. I mean, I think that your suggestion is really itemizing all those different all the statutes that imply a particular practice requirement. Would be good, but I don't know if we actually have that.
Well,
the reason
go ahead.
The reason I say that is I think that there's papers to sign, and then there's papers to sign. They're not all equal weight. And so the idea here is I think that within 1 or 2 pages, these policies could be outlined, and it would not be burdensome, and they could be succinctly written. And if you want to find out more about it, go here and here, but that it made an awful lot of sense to me that physicians ought to know, as an example, that there is mandatory requirement that you go to this database. We don't care whether you like it or not. You jeopardize the group if you don't go to it. So we don't want to be any. I didn't know. I'm sorry. I didn't know. Can't have that.
Yep.
That's brilliant. I think from a risk management perspective for groups, risk management perspective for hospitals and medical staffs. Wow, maybe we could push that on this level of ASAP as a best practice, or the AMA or something. I mean, because that makes a lot of sense to me.
Well, 20 years ago when I ran a department I was very big on a structured department meeting, because most department meetings are a waste of time. What we did, really, they could become bitch sessions in which people talk about what's wrong. Every month I had a section where 4 policies were attached, and were discussed. So at the end of 2 years, all the policies of the department had been presented again to the docs, so that they can't say, well, I didn't even know we had a policy on that.
Yeah,
Yes,
but-
we do have a policy.
Yeah, but the
on
problem is
that.
I can't wait 2 years to find out this policy. I just screwed it up today, and you're going to talk about it in 2 years.
Well, yes, but for the new docs coming on, you actually have time where they're taken through the policy manual. But you forget that stuff.
Oh,
so
that's
that
exciting.
well, Rick, I understand it's boring as whale shit is what you're saying. But the problem is if we don't do it, I think that's the problem. They can't remember everything, but if they know,
Right.
I think there's something in the book. We had a bomb threat policy. We had a tornado policy. I'm in Michigan. We had a snow emergency policy. So all they got to do is open the book and look at it.
Moving on. We for some reason,
All right.
the time is flying here. So,
I think
Carlo,
maybe I
give
have
us your best-
time for one more topic that I'll bring up, and this is something that this is a December 2014 article. It's called "Errors in EMRs: The Root Cause of Fallen Expectations," and in that article, I talked about how medical error is really
okay, guys, we just lost Carlos's sound. We are at 2:02. Carlos, can you hear us?
Carlo.
Carlo? Ricky, can you reconnect us all?
You guys stay on the line. Hold on.
Well, yeah, that hasn't done that for a while.
What happened?
He froze. His picture froze, then his sound froze.
Yeah, he's totally offline.
Yeah. Call him on your phone.
Let's see here.
Carlo?
Carlo?
Hello?
Carlo?
Yeah, I don't know what happened. I got bumped out here.
Yeah, you did. You froze. Your picture froze, and then your voice went. We're going to reconnect.
Okay.
So, Ricky, are you going to dial into Carlo?
Yeah, I'm trying to. I don't see him
Yeah.
online.
So, my son's trying to get into you now.
Okay,
Well,
all right.
He's not online.
I'll wait for it. Thanks.
Rick, he's not online.
What's that?
He's not online.
Oh, well, that probably has something to do with it then. Carlo?
Yeah.
Ricky says you're not online.
Let me see. I'm not online. Hold on 1 second.
That was the Verizon bill that the dog ate.
Yeah, if not, let me turn off my Wi-Fi, turn it back on.
By the way, you can't get mad at a dog that cute. So I mean,
So,
what can I say?
Ricky, Ricky's going to call you.
okay.
Okay.
He's on now.
Or-
Rick, how much time have we utilized?
Well, we were going to 2:20, but this and it's 2:05. But I think I think that this was probably a 5-minute interruption, so we're going to go to 2:25.
Okay,
But
perfect.
that'll be basically 2:25.
Okay, sorry about that, guys. Can you hear me?
Hey, you're great. We hear you just fine now. So
Okay.
where were we, and what comments were being made?
Well, what we can do is we can just take it from the top. The topic was help us out with the topic, Carlo.
It was errors related.
Oh, yeah,
medical
yeah.
Errors related to electronic medical records.
Yeah, well, just know that I have been duct taped across my mouth, and
Yes.
so I'm not in any position to say anything regarding electronic medical records. I will not interrupt. I will not.
Yeah.
You will not hear
Yeah.
any. You will not hear any. You will not hear any screaming. They're muffled behind the tape. All right, so let's begin.
Yeah, so this article that I wrote several years ago was my attempt at trying to identify and demonstrate that electronic medical records and the way they're built really don't help us out a lot. First of all, EMRs have such an incredible amount of information, 99% of which are completely irrelevant at the point of care, and it takes forever to find things. And not only that, you also have doctors and nurses on different interfaces, and now what happens is that they're not communicating in real life anymore. They're just entering into a document. And that just doesn't serve patients well in the ER a lot of times, and it provides risk. And that was kind of the intent of the article that I wrote back then.
Well, no argument here.
No. I mean, we're the last guys who are going to say we've solved all these problems. And I've watched excellent attorneys take doctors apart on their use of the electronic medical record. The worst thing is the pre-programmed history and physical, which the machine spits out. And to think that you've actually done all these things. And, the problem with doctors is they're not lawyers. Doctors don't lie well. And so when the attorney says, "Doctor, did you actually ask all those questions?" They say, "Well, maybe not all of them." And then, okay, so how much of the rest of this chart's a lie? You do have to be careful, because sometimes too much crap is too much crap. I'm going to give a talk next week to the EDPMA mentioning the fact that all of this is a billing rouse and scam, and it has nothing to do with the quality of the care. And since there's huge numbers of billers at this meeting, I'm sure they're going to love me for that. But bottom line is, it's a game, and everybody plays the game.
Yeah, definitely agree. I think that it really comes back to documentation then, because we shouldn't be thinking that an EMR will help us in any way, really. And in particular, because of these templates and things like that don't really accurately demonstrate what was actually done or what was actually conveyed to the patient in the form of informed consent, et cetera. We really need to be better at that documentation. And you bring up a really good point. It's really easy. It's really easy to walk a defendant into a corner, and all of a sudden the whole chart is suspect.
Yep. All right. Before we get away from this, in the April 2018 issue, Risk Management Monthly, we talked about sepsis. And Rick's sister, Jerry, who does most of the summarizing and editing work on Emergency Medicine Abstract, sent us an abstract. And we said, all of this stuff with the sepsis bundle, who says it works? Well, we've got somebody now who's published a paper who says the amount of good level A proof for anything in the sepsis bundle is essentially non-existent. There was no absolute good and then, sort of level B, that sort of level. No, it's opinion stuff. And yet my big complaint is, come a lawsuit, these things are all going to come out and say, "Doctor, weren't you supposed to do this?" We need to get enough people out there saying, you know what? There's no proof that any of that stuff works.
Well, actually, Carlo, this focuses right on the column that you wrote about sepsis. And this article that I have, Annals of Internal Medicine, EPUB before being in print. This was February 20th, so this probably hasn't even hit in paper yet. It's from, of all places, it's from the National Institute of Health. They basically are critiquing the Centers for Medicare and Medicaid Services, their sepsis bundle, and the performance measures that are associated with it, which require you to perform up to 7 interventions per patient to get checked off as completing the bundle. And basically, they concluded, here's the quote, there appears to be no high or moderate level evidence of a survival benefit underpinning the hemodynamic interventions recommended in SEP 1. The authors suggest that hospital accreditation and reimbursement based on adherence to SEP 1 may not be warranted.
What you're telling me, Rick, is that 2 federal agencies are fighting with each other. We ought to get the FBI involved in this and do some sort of big-time investigation.
Yeah, those of you who want to be a pain in the ass at the hospital, get the Annals of Internal Medicine, go to the articles that are in the EPUB status, and this is a rock your socks as they look at every one of these 7 things that they expect you to do and say not so fast with regards to their credibility. Greg, did you have anything that you wanted to do?
Yeah, I do. One of them is I want to shout out to Eva, and I'm not going to use her last name, but Eva just sent me a note, and she's a listener, says, the case that got me started listening to Risk Management Monthly was finally dismissed in summary judgment. Now, this thing has been kicking around for 5 or 6 years. It's awful, but it involved a mental health patient, and she said she was interested in the Bob Bitterman discussion on psychiatric patient dilemmas because she said she has no idea if she got in trouble for what she did, what's going to happen to the rest of emergency docs when this hits the streets. And I really do think this is an issue that ACEP has to take up as sort of a cause célèbre here. We can't have all of our emergency docs calling in psychiatric consults on all of these people. Can't be done.
Greg Weeks wrote, thank you. I've been following you and Greg ever since Risk Management Monthly began. Several years ago, 1 month after an episode that you and Greg talked about with spinal epidural abscess, I had a 20-year-old male present with back pain. It was 5 in the morning on Sunday. The physician assistant saw the patient and presented him to me, homeless, back pain, lower extremity weakness, and 100.4 fever, MRI, T4 to T9, spinal epidural abscess. Thank you. And then he gives another case where he picks up a postpartum eclampsia case and gives us a pat on the head for helping him not missing that one either.
Yeah. You know, when sometimes you can get advice on the phone and just because they call themselves cardiologist, general surgeon, whatever it is, if you don't feel right about that particular consultation, you're allowed to say something like, I think you ought to come in. I think we ought to see him together. We ought to do this or that. Because when they're sent home, all those docs say the same thing. If they'd only told me this fact or that fact, I'd have come running right in and we'd have admitted that patient. Sorry, but a lot of our attendings are liars, and they'll fold in a legal case. I've seen it way too many times.
Carlo, here's one for you. This fellow writes, when a patient has been admitted to the hospice service and orders have been written by the admitting hospice, but the patient is boarded in the ED, who owns this patient? Are both the ED staff and the hospice potentially liable for negligence should an adverse outcome occur in this case? I think that I gave you like that was a volleyball. That was a soft, that was a layup there.
Yeah. Now it's your job to spike this one right now.
Yeah, well, I wrote an article on this. I can't recall which. It was actually pretty recent. I think it was in the past 4 months or so. I think it was on bridge orders, kind of a similar concept, and it's really critical. First of all, for the hospitalist to accept care. That's one thing, and secondly, for the hospitalist to see the patient. That's the next thing. I think once you have that, then I think you're reasonably protected in terms of demonstrating that transfer of care. If you put in a bridge order, or let's say the hospice calls in an order and then they don't see the patient for a little while, it's kind of like the hot potato thing. I get a little concerned about that, and the other thing is that when you're talking about boarding, it's so common that the ER nurse will say, I could call the admitting doctor, but you're sitting right here, Dr. Reyes. What do you think about this? So we get kind of pulled in all the time in these cases. But I do think that, first of all, they should be the ones to be contacted. But obviously, to me, obviously, if there is an acute situation that's going on in your ER department, my practice is to help the patient if there's someone that needs help, whether it's a boarder in the ER or someone on the floor and they're calling me. To not act when someone's urgently or emergently having a problem would be kind of a problem, I would think.
Yeah, actually, can you envision a jury saying, "Doctor, you were 5 feet away when this guy's choking, and you're calling the hospitalist? Please." You say, well, technically the hospitalist had the authority over the patient. They don't give a rat's ass about that. Just
Right.
do the right thing.
Just do the right thing. Absolutely, 100%.
Yeah, then fight. You can always fight it out later, but to act is what the juries believe we're supposed to do. Non-action is very hard to defend in courts. Always be charged with some sort of, maybe you did it wrong, but you did something.
Yeah, but
and
listen,
I think that's probably good.
if Jerry Hoffman were listening to this, which I'm sure he's not,
Yeah.
he's going to say, "Don't just stand there, do something." No, don't just do something, stand there. That's his mantra. Don't do something, stand there.
Yeah, but Jerry's got to understand we live in a political world. So sometimes you have to do certain things, and Jerry may not like that.
Hey, listen, can I congratulate Jerry on how it's been going with regards to his bashing on the New York Times article, where it's kind of like he is a single-handedly been villainized over some people not getting their TPA, and the remarkable response that has occurred from people supporting him, independently reviewing the literature, saying I came up with the same exact conclusions that Jerry did. And I think he's done a nice job. There was really a nice interview just a couple of days ago. It's not out there yet, by Martha Roberts for Emergency Medicine News, oddly enough, who interviewed Jerry, and who Jerry went into his defense. And that'll be out there when that issue becomes available. I think it's the next one.
Yeah, we've all got to get behind him on this. The other thing is the New York Times used inflammatory language which should never have been put out there. It was, good docs save lives, evil doctors do this and that. Jerry was vilified for sticking to his point. Now, that's not a new role for Jerry, but I think the New York Times really has to be called into question for the terminology and they used, the way that the people were quoted. You know what? That's just not right. Jerry is a smart guy, and he's looked at this data a long time. I understand that reasonable people can view it differently. What you can't start doing is maligning his intent. What Jerry wants is to get to the truth. And sorry, that isn't always clean and neat. But Jerry, I agree. You took a beating, and what's the old line from Timex? He took a licking and keeps on ticking. So he's doing it.
Hey, listen, Carlo. This is kind of the end of the line here, and this is where Greg gets to talk to us about $5,000 bottles of wine that he's eating and drinking. The wine of the month segment. In fact, some of this wine may be from up in Las Robles. You guys are now becoming a wine center of excellence.
Yeah, that's for Mad Dog 2020, Rick.
No. They've growing wine up there. It's yeah, they are.
Yeah. Is there any place in California that doesn't grow wine these
Look
days?
at it, I got my backyard. I got some backyard.
Yeah. Okay. All right. Let me just hit a couple of ideas, and that is whenever you talk about Australian wines, if it's mid-zone wine, everybody quotes and talks about Penfolds. You've all had Penfolds. You can't have lived this long and not had and drank Australian red wines and not had Penfolds. Same way with white wines. The mass white wine of Australia is something called Yellowtail. And if you've ever been to a reception, at any of the medical meetings, this, that, or another thing, you've had Yellowtail. You can't get away from it. Well, now, Western Australia, in the Margaret River Valley area, is coming up with some pretty damn good stuff. And I'm going to recommend one for you. This is Cullen Wines, Cullen Wines, the 2015 Ephraim Clark Sauvignon Blanc Semillon, and a white wine rated at 94. So all of a sudden, we now have a reasonably priced Western Australian wine, which is worth trying. I recommend it to you. 2 nights ago, we were fairly sloshed on this stuff, and I can say it had very little hangover the next day too, which is always a good thing to note.
All right, Gregory, thank you for those words of wisdom. Geez, Louise. And Carlo, thanks so much for coming on with us and tolerating this abuse. And I do read your column, and I think you have a lot to offer. And hopefully you'll come on again, because I think that this may be an opportunity to present your views to another group of people.
Yeah, Carl, I would like to reiterate that. And next time, we're even going to let you talk a little bit and will not totally occupy your time. So for Carlo and for Rick and myself, Greg Henry, we're saying goodbye for May 2018.
There you go.
Yeah, we're done.
Rick, can you stop your recording?
Can I stop my recording? Let me find the little box.
Now, Carlo, that wasn't so bad, was it?
That was a lot of fun.
It was
Thank you
like,
so much.
It was like going to a dentist.
Yeah, and by the way, you've got our phone numbers. If you have a hot topic, you've researched an area, if you want to have discussions about what I think we ought to do for the residencies in emergency medicine, just to throw those ideas around, just give us a call. You don't have to wait for us to call you. You call and say, we need to do a show, and this is the issue I want to talk about, and we'll do it.
Yeah, although it's taken us a long time to connect with you, I'm not sure. I have no good reason for that to have occurred, because we do read your papers. It was just kind of a light bulb on one day, and this guy lives up the street, for crying out loud. So if it's okay, we may periodically be hitting you up for content, opinion, cases, those kinds of things. And like Greg says, you're welcome on anytime. And we don't have to, frankly, do a whole we could do like a 10-minute segment on a story that you think is a hot story that we want to get out there, kind of thing.
You know, and we can call you up and say, we want 1 minute thought on this. There are plenty of other people who do that to me. I get calls from Mel Herbert who say, Greg, I want 30 seconds on this topic. That's it.
Greg, you've never given 30 seconds on anything in your entire life.
Well, except sex to my wife, right? So,
Well, that sounds fantastic. Thank you
Yeah.
so much, and I hope to engage hopefully on a regular basis with you guys. That would be awesome.
That would be terrific.
okay. Goodbye.
Ricky, are
Take
you
care.
there?
Yep.
Okay. Did you capture yours?
Yep.
All right. I'm going to try to identify where this silence was so that our editor can not have to listen to this entire thing. It would be unduly painful.
Yep.
Carlo, thanks so much.
Bye bye.